Hi, everyone. It's so lovely to see you here again. And thank you again for coming to our monthly Luke's Legacy Family Research Rounds. For those of you who may be new to the process, this was an idea started as a part of our knowledge mobilization initiative through the Family Engagement and Research course. And the Family Engagement Research course is a 10-week course for families, advocates, and researchers, trainees to all come and hang out in the same space. And we learn more about research engagement and partnerships and all the things that kind of go in between. And so the reason why we decided to do this was we also thought that it was important for research information to be put in the hands of people living the experiences that are being researched. And so that's what brings us here tonight. With me as always, oh, I should actually introduce myself here. I forgot to mention my own name. My name is Rachel Martins, and I'm a research engagement strategist with Can Child and Kids Brain Health Network. And with me as always is my partner, Kinga Posniak, who we coordinate this together. And tonight we have the privilege of having Dr. Katie Birnie. Oh my goodness, I was going to say Bernier. I've been talking to my genetics, but anyways, different person entirely. And Mylene Pinet. And
yeah.
Sorry?
Oh, Rachel, I figured that. My name is actually pronounced Mylene.
Mylene?
Yes.
My apologies. Thank you.
No, that's okay. I thought about bringing it up right at the beginning, but I thought I would just take a guess. And
I just see the accent
right
on your thing now too, and that's going to be in my brain now. Thank you. I appreciate the clarification. Sure. We're going to talk about SKIP, which is an amazing initiative that has come out, as well as it says in the slide here, about solutions for kids in pain. But I don't need to be the one to expand on this. Let's talk to the people tonight who came to host. We're so grateful that you both came. And I hand it over to you, the microphone.
Awesome. Thank you so much for having us, Rachel and Kinga. I'm Dr. Katie Birnie. I'm a clinical psychologist, and I'm an assistant professor and researcher at the University of Calgary. And I'm also associate scientific director of SKIP. So really excited to be here to share about SKIP tonight. And I've had the privilege, I can see a couple of people online that I've had the privilege of knowing and working with in different capacities with regards to partnership around improving pain management for children. So excited to share that, and really thrilled to be here with Mylene as well. Mylene is SKIP's communication and engagement coordinator. So we'll share a little bit about her role, her experience, and how all of those pieces fit together. And then we're hoping to just have a conversation. So we'll take about half an hour just to share, and then look forward to dialoguing with all of you about the topic. So I first just wanted to set the stage, I think, about what patient partnership is and patient engagement. It's something that people increasingly talk about, but sometimes people still don't know, or we use a lot of jargon. So I think it's important we talk about what do we mean when we're using that language. And this really differentiates from patient partnership, or patient engagement really differentiates from research participation, where you are participating in a research study. But patient engagement is really research where people with lived experience are partners or members of the research team, deciding what is studied, how it's studied, all the way through to the knowledge mobilization component. So how it's shared, how we're making it available to other parents, family members, the public, to policymakers and decision makers. And there's really a continuum of engagement. So traditionally, historically in research, which still happens, is the role of the person with lived experience is to be a learner or to be informed about the science. But increasingly, we're moving along that continuum where the person with lived experience is more and more and more involved, in an advisory capacity, an equal team member, or in some cases, through some of the work of Can Child and others, to lead. It's actually people with lived experience who are coming up with the research questions, who are really leading what projects look like, and researchers or healthcare professionals like myself are in more of that support role to actually empower and enable. Before I talk about SKIP too, when we were preparing for this talk, when Rachel and Kinga and I met to talk about it, we thought it would be helpful to share a little bit about what are some examples of how parents or youth have been engaged as equal members of a research team. So in addition to my role with SCIP, I'm an assistant professor, like I mentioned, and a researcher, and I run a research program called Partnering for Pain that really takes this approach of having youth and parents or caregivers as equal members of the team on the projects that we do. And a lot of these are based around a priority setting project that I led a couple of years ago, where we engaged hundreds of youth and family members and healthcare professionals across the country to identify the top 10 most important things that they think need to be researched or improved about chronic pain care for kids in Canada. So it really was emphasizing kind of those who typically traditionally don't get to decide what research is done, and putting their voices at the forefront. And so a lot of my research now comes from, okay, how do we actually action these top 10 priorities that were there? So we run a couple of different projects right now. The top 10 priorities I mentioned, some of them are about how do we prevent pain and actually co-design health services. Some are how do we improve pain assessment for youth with brain-based developmental disabilities. Some of them look at how do we treat pain in families. Chronic pain tends to run in families, and our health system is not really designed to support a whole family, right? It's got our pediatric system and our adult system and our mental health system all separate. And also, how do we look at best practices for virtual care? So that was some work we started in response to the pandemic. And so we've engaged parents and youth to come up with research questions. So what's the scope of a project that we're looking at? So just to give you an example, we're doing a review right now around how to best assess pain and pain experience in youth with brain-based developmental disabilities. We have 3 parents who are members of our research team, and they helped us determine the scope of what we're looking at. So we're not just looking at how intense pain is, but we're also looking at other aspects of pain experience, driven in part by some of their ideas. And we're also looking beyond what we might think of or traditionally look at in some of pain science, like surgeries or chronic pain, but looking at some of those pain experiences that really are day-to-day decisions for parents. How do I tell if my child's constipated and assess pain from that? You know, if I have a kid with autism who's nonverbal, or you know, how am I looking at pain from like dental caries, like cavities, right? Like things that verbal youth might be able to more effectively communicate, but might struggle, nonverbal youth and their parents and caregivers might struggle to differentiate more between pain and other distress, right? Even hunger or irritation or other things like that. So they're really driving, you know, some of the questions we're doing there. And the other example I'll give is the virtual care project, where we actually did a call for virtual care innovations across the country in partnership with SCIP and a pan-Canadian organization called the Canadian Foundation for Healthcare Improvement. And youth and parents were involved, along with healthcare professionals and health systems leaders, to evaluate some of the virtual care innovations that were submitted, to identify, you know, were these actually, how were these actually filling needs? And the top 2 but from that group were selected for a $5,000 knowledge mobilization grant to help them, to help give them some funds to actually spread and scale and share their virtual care innovation with others. So youth and parents were also involved in that regard as well. So happy to chat more about some of these examples, but just to give you a sense, there's an incredible array. The more creative you are, the more variety of endless ways that people with lived experience can be involved throughout the whole continuum of the research process. But one of the reasons we're here talking tonight too is that it's great, we can create research knowledge, but there's some estimates that suggest that it takes about 17 years for new research evidence to actually impact practice, or to actually reach the people who can use and apply the knowledge today. And I know I'm preaching to the choir a little bit, but when we think about children and youth, that's a whole childhood of youth who are missing out on the science that we already have. So we need to bridge that gap. We need to shorten that 17-year period so that new science that comes out today, people who can use it tomorrow are able to access that as quickly and easily as possible, in a way that they can understand, that we're not just sharing this in a scientific publication that's behind a firewall and isn't accessible. We're actually creating tools and resources to enable people to act. So this is where SCIP comes in. So if you didn't know before, I'd be happy to share that actually Canada is a world leader in producing children's pain research. So there was a review by an organization in Canada that looked at all the different areas of science produced by Canadians relative to our population size. And pediatric pain was number 2. The first was like fisheries. So just to give you a sense of the scope of scientific topics that were looked at. But so we hit above our weight in terms of creating new knowledge about how to manage pain in kids. But we also know from a lot of studies, and many of you may know from your own firsthand experience, that knowledge isn't always being put into practice. So even though we know how to do it, we're not necessarily doing it in all of the spaces and places within which children are living and interacting with the healthcare system. So SCIP's vision is really healthier Canadians through better pain management for children. Our mission is to do that, is to improve children's pain management by really mobilizing science-backed solutions and doing it in partnership. So working in coordination and collaboration with different partners, different audiences that want this information, that need this information, and that have creative outlets for us to be able to share that information effectively. And our goal, our outcome, is to improve children's pain management in Canadian health institutions. And that doesn't just mean the specialized tertiary care children's hospitals, because we appreciate that most care or most interactions that children have with the healthcare system are actually outside those settings. They're in community or regional hospitals or other clinics. And our goal, our impact over the course of our network is to reduce suffering, have greater engagement in necessary healthcare, lower risk of chronic pain, mental health issues, substance use issues into adulthood, make things more affordable for families and for the healthcare system, and that we're a leader in using the knowledge we have about how to prevent and manage children's pain effectively, not just in producing it. So SCIP is what's called a National Knowledge Mobilization Network. And Rachel used this term when we were starting at the beginning. And what we mean by knowledge mobilization is really this bridging that gap between research and practice, or between research and families and other policy and decision makers, mobilizing that knowledge. And we use a hub and spoke model to really build a network across Canada to enable that to happen. We're based at Dalhousie University. I'm actually here in Calgary today, but our administrative center is in Halifax. Dr. Christine Chambers is our scientific director, and SCIP is actually co-led by Children's Healthcare Canada. So they're our partner organization. So Emily Grunwald, who's CEO and president of Children's Healthcare Canada, also fills the role as SCIP's knowledge user director. And then we have a number of administrative staff that support our network from an operations standpoint, as well as Mylene, who's here today to talk about her role as communications and engagement coordinator. But our hub and spoke model is really driven by our 5 regional hubs across the country. We have one in Ottawa at Children's Healthcare Canada, one at the IWK for Eastern Canada, led by Dr. Alan Finley, a new Francophone hub in Montreal, co-led by Dr. Marie-Joëlle Doré-Bergeron and Dr. Evelyn Trottier, one at Tickets with Dr. Fiona Campbell and Dr. Jen Simpson. And then our Western Canada hub is based in Edmonton at the Stollery, and it's led by Dr. Samina Ali. And all of these people are, with the exception of Emily, who I described, the others are healthcare professionals and leaders and researchers in the field of pain in children, and real advocates as well for pain in childhood. So they are kind of a bridge as part of our network. And then each of them have a full-time knowledge broker who works with them to mobilize knowledge. And these are 5 dynamic, diverse background individuals who've worked in policy, who've worked in community health, who have worked in like just a variety of interesting backgrounds to use this role called a knowledge broker, which is new. It's a new term people haven't necessarily heard before, but it's essentially people who have expertise in bridging that gap, right? So they understand the scientific process, but they're not academics, they're not researchers, they're not healthcare professionals, and they really work in partnership with different organizations and those different stakeholder audiences to get that information out there. And I should add that each of the regional hubs works with different children's healthcare institutions within their region as well. SCIP is also what's called a Patients Included organization. So if any of you are not familiar with the Patients Included charter, it's worth looking at just to be aware of. Basically, it's a commitment to engaging or partnering with people with lived experience for us at different levels of the organization. So SCIP has a board of directors, which has youth and parents with lived experience on it, in addition to others. We have members of our staff who are people with lived experience, and we partner with people with lived experience in all of the activities that we do. So if it's presentations, if it's webinars, if it's co-creating a new tool, if it's developing a health standard, youth or parents are at the table and part of the conversation and co-creating and co-producing with us. We have more than 100 diverse sector partnerships. Some are more patient-facing organizations, some are Health Canada, pan-Canadian funded healthcare organizations, and some are like private companies, small companies that do graphic design that we partner with, or other platforms to reach healthcare professionals or health systems change makers, or other communication outlets. So like the Conversation Canada, where we can do articles that are intended for the public to reach different places. And our goal is really to work in partnership to get information about children's pain where people are already going. So our goal is not necessarily to become the sole singular place where you can get the best evidence about children's pain. In fact, if that was the case, we would have failed. Our goal is that we want this information everywhere that people are going to look for information about blood draws, to look for information about surgery, to look, that it's everywhere that people are already going and the spaces they're already in. So we just kind of take over the world that way. So with that, I'll turn it over to Mylene.
Thanks, Katie. Hi, everybody. My name is Mylene Pinet, and as Katie and Rachel had introduced me, I'm the Communications and Engagement Coordinator at SCIP. I recently graduated with my Bachelor of Public Relations, but I've worked in healthcare communications since about 2019. And I always knew that I wanted to work in healthcare communications because I am one of those staff members. I'm a person with lived pain experience. So I have a genetic condition that for me causes a multitude of challenges, but one of which being widespread chronic pain. And when I was 13, 14, I had an incredible positive experience with a communications coordinator at the IWK Foundation here in Halifax. And I thought and realized that you really don't need to be a brain surgeon or like an anesthesiologist to make a really big difference in healthcare and pain care. So I went with communications instead, and I have since learned that there are a wide variety of incredible people that make such an important impact and difference. So at SCIP, I wear two hats, communications and patient engagement, but they actually blend really well together, which is what makes my role quite unique. In communications, I handle all of SCIP's social media channels. I help manage partnerships. I create internal and external content, but I really just help support SCIP and our partners in any communication output really in general. I also work really closely with our communication specialist, Sherry, and we build really any of the content that you see on our website or our newsletter, posters, visual assets for our hubs. And like Katie had mentioned, comms is typically involved in a lot of the activities like webinars and conferences. And then in patient engagement, I really just work as an advocate for our patient partners. I provide our patient partners with opportunities that fit their unique needs and experiences. And I make sure that the researchers are well supported, just as well as the patient partners are, to make that activity smooth and seamless. And I really just try my best to make sure that our network and our SCIP team members are engaging in meaningful and thoughtful patient partnership. Next slide. So as Katie mentioned too, we are a Patients Included organization, which means that we believe in meaningful engagement and inclusion of our patient partners in all levels. So our activities, in our governance, and as well as in our hiring processes. Patient engagement is something that we really strive to embed in all of our activities at SCIP, and we do that in a couple of ways that I'm going to share with you now. So one of those ways is our Patient and Caregiver Advisory Committee, or our PCAC. And this committee helps guide and inform our work, specifically when it comes to patient engagement. So our members help to advise on like the design and the implementation of patient and caregiver activities. That includes the development of projects, how we evaluate patient partnerships, as well as on our reporting processes. So we meet about 4 times a year, but the committee is also very active by email, on social media, and are engaged in many activities throughout the year. And then one thing that I really appreciate about SCIP is our transparency. And we're always working really hard to improve and to learn, and really just trying to be a leader in patient engagement. But that certainly does not mean that we're not still learning. And I mean, I know that I learn every day that I come to work about different needs and gaps that exist in this patient partnership world, and how to do partnerships thoughtfully. So one way that we're trying to implement that at SCIP internally is through a patient partner pathway. And this process is still underway. So unfortunately, I don't have something very concrete to show you at the moment, but I wanted to talk about it because I think it's a way that keeps me, our hubs, and the rest of our network really accountable when it comes to patient engagement, to not only have us do it well, but to one day be able to teach other organizations to be able to do it well, but also have patient partners know their rights and know what to expect when they're engaging in these kind of activities. So it's an internal document that helps just provide a framework on steps to follow to ensure that we're doing this thoughtfully. And it lays out several different paths of patient partnership activities. So for example, keeping in line with research, if SCIP is looking for a patient partner specifically to engage in research, what does that look like? So we start out by connecting with the researcher and the patient partner or the project coordinator to just understand what the need is, like what's the project, how does it relate to SCIP, and who at SCIP is involved. And then I work to connect the patient partner and the researcher to ensure that those expectations are understood and that those expectations can change. So that goes beyond the research project. So we discuss how the researcher and the patient partner will connect, whether that's by phone or email, a Zoom call or a text. Sometimes it's through me. And I'm sure, as you all know, that things change when you live with pain, or caring for someone who lives with pain. So it's really my job, of anyone at SCIP in the network and on these activities, to make sure that we respect health requirements and changes to these requirements, as well as any other need or just general support that a patient partner requires throughout the course of the activity. And then later, we evaluate the partnership. So typically this is done through a survey to our patient partner, by email, by phone, or by text. But this survey just kind of asks about their experience, prompts them to share anything that they liked, didn't like, and whether their own expectations were met or not met. However, evaluation happens over the course of the entire activity, and that's going to depend on the activity. So I always make sure that the patient partners know that I am there to check in for a call or to chat, as well as with the researcher, to make sure that everything is going smoothly. So although we think of evaluation as something that happens at the end, it's really just about building rapport and maintaining that relationship to ensure that everyone feels comfortable throughout the entire activity, and knowing that people can say yes or no at any time that they choose, to make sure that they feel safe and comfortable. Next slide. And we also developed compensation guidelines for patients and caregivers who contribute their time and expertise to SCIP's efforts. So this includes anything from board members, working groups, providing feedback on a document, attending meetings or workshops. And these guidelines essentially just outline how much patient partners should be compensated depending on the work that they're putting in. And of course, we believe that patient partners should be compensated for their time, but it's also important to note that not everyone wants to be compensated, which is where some of that overlap with our patient partner pathway comes in. So it just outlines that sometimes they don't want to accept compensation, or researchers don't have the means to provide compensation. And this kind of gives an outline on why we think it's important and how it can be embedded into activities or research projects. And these guidelines are found on our website, and they're really for like researchers, any organization to use. And a part that is always really fulfilling is when we get an email or a message saying, where can I find them? Because it just kind of emphasizes that people who might not know that this is an option or was an option is really being valued in these research activities now, and that people are coming to SCIP and organizations alike as leaders in this kind of field. And next I want to talk a little bit about some actual patient engagement activities that I have been involved in, just to provide some more examples. So last year, just to give some context, SCIP engaged with about 26 patient partners in a variety of activities. One of them that I was heavily involved in was a guide to chronic pain in students. So it was an in-school resource. This resource provides teachers and school staff examples or staff information about chronic pain in youth, but also examples of strategies that can be used in class to cope with chronic pain. And after the first draft of this resource was developed, we put out a call, just a general call for feedback. And this is where my comms role and my patient engagement role really overlap. So we put out this call, not only for teachers and school staff, but also for students and their parents and caregivers. So I really just took to social media and I said, hey, SCIP needs your help. So people who showed interest reached out directly to me to provide feedback. And then I shared the document and a resource. I'm really just asking their thoughts, like, is the document helpful? What's missing? What would you change or add? Is the format accessible? Would you use it? But beyond sharing that general call for feedback online, we did some very specific reach out to our patient partners that we knew would be excited to engage with the activity or had expressed some interest in like school-based resources, at which point we offered, of course, compensation for their time and feedback. So it's an example where we went to the general public for public review, but we also specifically engaged in patient partners with experience with chronic pain in school, at which point we compensated them for their feedback specifically. Next slide. And then I feel like I keep saying this, another part that I like about SCIP, or patient partnership, is the opportunity for patient partners to tell their story the way that is most authentic to them. Storytelling and patient partnership, I think, is a very important, very impactful thing to do. There are best practices that we're always still learning on creating like safe trauma-informed environments. And last fall, we had this incredible opportunity to partner with an organization to launch a blog series. So the blog series was called Painfully Aware. The author is a young person who lives with chronic pain, and they told their story exactly how they wanted to, the good, the bad, lessons that they've learned, like hopes, dreams. Really, they included everything that they wanted. And it was a unique opportunity for us. It was a partnership with the chronic pain and clinical research team at Children's Hospital in Manitoba. And we were really able to support the patient partner through the whole process. So from writing and editing to their comfort level in staying anonymous throughout the whole thing, making sure that they were compensated in a timely way, and just overall feeling supported through the whole process, which can be quite emotional going through your story. It's not always an easy thing to do, but brave and impactful. So it was nice to be in a position where we were able to really just be a support to them. And then I left this part for the end of my presentation because I learned that you want to leave the audience with something to think about for the end, because it makes it a little bit more memorable. And I have a thought or a prompt for you. SCIP has a patient partner database. It includes about 100 patient partners who have expressed interest in being engaged in SCIP activities. So the survey that you can see on the screen is tinyurl.com/let's-skip, and it signs you up as a patient partner. So when opportunities arise for partnerships, we have this beautiful internal database to engage with. So all of the activities so far that I have mentioned have included people from this database, but sometimes they also come from like unique connections or networking from other people outside of the database. However, it is a great resource to have because we are able to really target opportunities to patient partners depending on their really unique experiences. So if you haven't signed up already, or you know someone who would be interested in engaging with SCIP activities, feel free to visit the survey, submit your information, and that way I have it so that we can connect. And this year, one of my main priorities is diversifying the database. So a few months ago, we sent out a demographic survey just to get to know a little bit more about our patient partner database. So the PCAC and I right now are working on recruitment and onboarding strategy to fill more seats on the committee, just to make sure that we are representing people well across the country. So it's just a way that we as an organization are working to engage in different types of patient partners. So Indigenous peoples or racialized groups, making sure that voices are at the table and we are, actively engaging with people that, want to be engaged. And we know that's important, of course, to engage with people from all walks of life. It's not just a nice thing to do. It's actually a very critical part in improving people living with pain and moving our mission forward. And that type of engagement also helps us figure out and understand like what types of activities people even want to engage in or want to be involved in. So Katie, if you want to, is that the next slide? Yes. So this is where I kind of want to plant the seed. We have a couple of different ways that you can let us know what you want to be doing and how you want to be spending your time with SCIP. So at the end of the survey, there's a section, it's like a checkbox, and it's, I want to be involved in providing feedback or social media or working groups, but there's also that very generic box at the end if you have additional comments. But if you have ideas or you have engaged in an activity with a different organization that you think would fit SCIP as well, or you have an idea for a video or a story that you want to tell, that of course is where we would love to hear about it. Or you can always email me if you want to connect or you want to talk about patient partnership in general. If you have an idea and you don't really know where to get started, that's kind of where my role comes in.
I was just going to say, Mylene, one of the areas that people could also contact you is, since you manage SCIP social media, if you like to DM on social media, Mylene is also the person at the other end of that.
It's the bonus.
Which is a nice way to, it's a bonus. Yeah.
The bonus of going through, being able to scroll through Twitter every day.
Exactly. So there's lots of ways to get connected with us, and we're doing a variety of activities. So I'll kind of stop here. That was really kind of that was the formal presentation that we wanted to share, but SCIP's work looks at assessing needs. So what do people want to, where are their unmet needs around pain management in children, either a lack of evidence that exists, or also there might be evidence, but it's a gap that's not being met by tools or resources or other information that's out there. Then we go about co-creating those with partners or with people with lived experience. One of our other priorities is to facilitate institutional change at those healthcare centers across the country, from the ground swell level all the way up to, or top down from those like leaders, right? Like the CEOs, COOs, like of the hospitals as well, and even provincial health jurisdictions or otherwise, and federal policies. And then our last one is to create urgency. That pain in children is an important issue. To create public awareness and urgency that we need to act on it, because it matters now, and it also matters for these children and their families over the course of the rest of their lives. So yeah, I'll stop there, but really looking forward to a conversation with all of you.
Thank you both. This was absolutely marvelous. And it's so nice to see how much has changed. I've been a part of CanChild for about oh gosh, 6 years now. I'm not sure where the time goes, but to see how things came from inception to where they are now it's just so lovely to be kind of an outside participant and sometimes participant in the process as well too. So now this time within our research rounds is usually an opportunity for conversation. Any questions? We do have one in the chat, but if any of you have questions as well too, please feel free to either come off mic or put it in the chat as well too. We want to ask away things here as well too. So one of the things was pain related, and it was talking about whether or not you guys have delved into the subject of paramedical therapies for pain management, such as massage or facial work or things like that.
Yeah, that's a great question. We always look to some of the evidence that exists, and we're also looking to what evidence exists and where are there knowledge gaps in the evidence as well, and using it as opportunities to also converse with researchers to say, hey, look, people are using this or wanting to know more about this. If there is evidence that exists, we can share that. If there isn't evidence that exists, we can say, hey, there needs to be more about this as well. So we also use our platform as an opportunity to point out gaps in knowledge where we can, and to try to mobilize people to address them. So some of the ones that you talked about, some have some evidence, some have less evidence, and some things are also harder to study. I just want to articulate that. Diet is a really good example of that. It's very difficult to really strictly study diet the same way that some other areas of science are, like medications, for example. But we're integrating some of this. So as in my role with SCIP, I'm also chair of a national working group with one of our partners, the Health Standards Organization, where we are developing a national health standard for pain management in children. And that's really because we want to move the base level of care for kids in Canada. Like, we don't even have like a base standard of like what's acceptable for managing pain in Canada. So that's one of the things we're working on. And we have 3 people on that working group who have lived experience. And one of the people on that working group, who's now an adult but has had pain since she was a child, has brought up some of these as topics as well. So how do we tackle these at a level of creating policy or at a level of creating standard for things that don't always have the rigor of science that sometimes we want to base kind of guidelines on. But nevertheless, we need to talk about and acknowledge and figure out where they fit in, because those open conversations of what people are doing and how they're doing it is also really critical as well. So I don't know if that answered the question, but I think about that in a lot of different ways. And it's really important that it's part of the dialogue that we're facilitating, I think, between researchers, people with lived experience, health professionals, and health systems around it.
I think that's a great point that you raised, just in the fact that where there are gaps, implicit bias has a way of kind of inserting itself in there. And that's when there are safety issues, et cetera, that come out of that as well too. And there's another question here, but I think that it really comes to something I was going to ask you anyways, which was
Mylene was going to add something, Rachel, if you don't mind.
My apologies,
yeah,
Mylene.
go for it.
Oh, no, sorry about that.
No, it was something small that I wanted to add to. I came into SCIP with very much my own bias and thinking that, as I mentioned, like healthcare and pain care is like brain surgeons and anesthesiologists, but SCIP engages with so many different types of healthcare professionals. And we have this program called a Pain Champion program, which I just find so incredible. We have these occupational therapists and just a vast like scope of people in different healthcare institutions across Canada that work to apply this research in their like day-to-day work. And they are always so candid about sharing their stories and how they apply this research and what they're doing just to inform their like families and the people that they engage with on a day-to-day basis. So it's not that we're just sharing this broadly to the general public and hoping that but like when you picture a doctor in your head, those are the people that get it. It's really everyone at every level of health professions receive that information.
For sure. And that you bring up such a fantastic point about the fact that knowledge is kind of an intimate affair to some degree, because you connect so much about trust as well, in terms of how that how you process that, how you cling to certain bits of knowledge, things like that. And all the more so with pain being such a highly psychological thing, like you have any sort of connection or some support community just really plays to that person's benefits. That's wonderful.
I'll add to it too, Rachel. I think one of the things that I find enjoyable about working in the pain space, but I think also gives us a lot of room for impact, is pain touches, like, it's really hard to not be touched by pain in some capacity. You know, if you're a generally healthy child, you might be going out to get your immunizations, or, you know, you might break a bone at some point, all the way through to you're someone who lives with pain every day, or you're someone who's had dozens of procedures or surgeries or other kinds of things like that. And so I think we're also trying to talk about it in a way that's not a separate entity, I guess, from the rest of how people live or the rest of how people interact with the health system, right? So, you know, because it's going to show up, you were alluding to trust and conversations, and Mylene brought up like trauma and those kinds of things. Like, this is also integral to how we identify, prevent, and manage pain well, is acknowledging that like it relates to all of these other kind of factors at play. So yeah, I think that's important.
I absolutely adore that you bring that up, because that's something that commonly is a part of the disability community. Someone may have an experience or a bad day and someone goes, well, it's not quite as bad as your experience. It's like, well, this is not a contest. This is a spectrum of experience.
Yeah.
Agreed.
And yeah, so I just love that. The next question I have here talks about the disability community and the fact that what sort of strategies, conversations that you've maybe had, work, future work, big visions, whatever you like, really honestly, about deaf, hard of hearing children, nonverbal children, things like that. Anything that you could touch on would be awesome.
Yeah, gosh, this is like a whole area. And I will say there's both a knowledge gap and a knowledge mobilization gap around some of these topics. So I've encountered several families along the way who, you know, there are some, I'll talk about pain assessment just as one example. Like, there are some tools that exist out there. Like, there is something called the, I'm going to get the name wrong, but it's the nonverbal communicating pain children's checklist. It has a very long, not accessible name. But it looks at pain behaviors. It's kind of a checklist of behaviors that are potentially indicative of pain, especially when combined together. So it looks at things like facial expressions, distress, you know, other distress, crying, might be tension in the body, right, arching, or other kinds of things like that, similar to some that exist for infants, right, who also can't express pain. And I've encountered families who never heard along the way that something like this even existed, which is a knowledge mobilization gap, right, to actually be able to share that those tools exist. But then, of course, there are still a lot of gaps. Pain is one of those things where, you know, you can go for an MRI or an ultrasound or a CT scan or a blood test, and you still can't necessarily see pain, right? Like, there's no biomarker to say pain is present. And I think that makes it tricky because there's no, pain is inherently subjective, right? And so I think that can make it really challenging to identify. I think this is where I see also a really important piece for partnership with people with lived experience, because who often knows those children best? The people who are caring and are with them a lot of the time, right? So it also becomes like, what's different behavior for your child than what's typical for your child? But there's a lot we're doing. I mean, the pain science, we said there's a lot that already exists. There's a lot that is actively learning about like genetics, neurobiology, neurophysiology, at the cellular level, the molecular level, like that science is still very much progressing. So I think we're going to learn a lot more about pain over time as our technology evolves. But you don't want to have to wait for that, right? As a parent of a youth right now who's navigating that. So, I think some of those, so we're doing some more pieces around pain assessment. Like I mentioned, where we're looking at all the tools that exist. I think we'll also be noting gaps. I think we have bitten off a large chunk of kind of a larger project than I expected when we first started it, because we're also wanting to not just look at particular populations that have received more focus, I guess, in terms of children who don't communicate verbally around pain assessment. So there are certain populations where that's been studied more or looked at more. So children with cerebral palsy is one example. Children with autism is another example. But there's so many different rare conditions, genetic, metabolic, other functional kind of conditions, where we haven't actually consolidated a lot of what do we know about how to assess pain in those conditions. So we're really looking to make some recommendations about what pain assessment tools exist, either for youth to self-report as much as possible, or for parents or observers, but also to identify gaps so that we can clearly say, look, this population or this group or this type of pain or this type of pain experience needs to be assessed more, recognizing that it's not just about intensity, right? It's also how pain impacts children. So that's one. I would say there's also some very cool work funded in part by ChildBright that's looking at distinguishing between pain and irritability, particularly in children who are nonverbal, because that can be difficult to distinguish, right? Is it that my child is in pain, or is it just that they're irritable? Because that can also happen because you had a bad sleep, or because, whatever, right? So there's some interesting work going on there right now. I would say that's come up. I would say SCIP is partners in a lot of different projects as well. So we get to see what other researchers are doing. And there's another great clinician scientist who works in complex care at the University of Calgary and Alberta Children's, who's also doing work around kind of trauma and for youth with medical complexities around hospitalizations and medical trauma, and how it's kind of more broad than that, but pain is a component of that, because oftentimes painful procedures or pain experiences and how those are managed can be a source of trauma for families. So if you're asked to restrain your child, for example, during a medical procedure, that can be quite traumatic and unethical, depending on what kind of context we're talking about. I'll just say that. So I think there's also components of trying to understand it as it relates to medical trauma too. Yeah, so those are some. I think there'll be more and more, but those are ones that come to mind as we're talking right now.
That sounds fantastic. And what's lovely about sessions like this as well too, much like if you would go to any pediatric grand rounds, you have colleagues hanging out together and you can give suggestions on people's work and things like that. And we try to encourage the same sort of environment here as well too. And one great suggestion that we had from Marie was a charge syndrome pain assessment for non-vocal pain assessment. And I did not know that existed. And I think that is super cool. And I'm going to give that a read here this evening as I have my dinner. Kinga also asked a question about working on defining an acceptable level of pain in kids. Can you talk more about that? Giving you hard questions today.
I know, these are good questions. These are tough questions. Yeah, gosh, it's one of the things working on this health standard that we're developing, which I will plug is coming out for public review at the end of November for 60 days. And we will be sharing it with this group and would encourage you all. We're trying to make it more accessible so you don't have to read the 40-page document to provide comments, but would welcome comments as much as possible from as many people as possible about it. And I bring that up because it's been a humbling experience for me to think about language, when we use terms like acceptable, when we use terms like optimal pain management, when we use terms like quality pain management, like what does that actually mean? Because pain is such a subjective experience. And there are some instances, we can't promise a pain-free life. Pain is a part of, it's a part of being a person, a human, that we're going to encounter pain, even just acute pain or day-to-day pains. So one of the ways we've actually tackled this in a research study I did in the past was, and how people use pain scales and how much pain they feel or how much it bothers them hugely varies depending on how they make meaning of it. What's the source of the pain? I always think there's a great distinction between labor pain versus like, some sort of accident, right? Like those can have very different meanings to different people, just depending also on spirituality or religious beliefs. Like there's so many factors that go into pain experience. So it's really hard to define that for any one person. We've tried to tackle this in the past. When I did a study of I was at the IWK actually in Halifax. We asked all children who've been hospitalized in the past 24 hours on 3 different days over the course of a year to rate how much pain they'd experienced, what their pain care had been like in the last 24 hours, procedures, all sorts of things. But we also asked them this question, which was, how much pain are you okay with before you want help, before you need like more medication, or before you need help from an adult? Because we often assume that all pain is like not tolerable as well. And that every youth is going to have a different threshold. Every person is going to have a different threshold where you decide, actually, for this, I do need to take an Advil, right? Where someone else might be like, nah, that's good. I need it to be like twice as bad. Or, like how we actually need to manage it in the moment can vary for different people. So then we looked at how they rated their pain against how much pain they said they're okay with before they get help. And then we used that as a means to say, if you're reporting pain higher than pain that you're okay with, that's undermanaged pain, right? If you're reporting pain that's below where you need more help with, we didn't use the word acceptable, but I'll use that word here, Kinga, because that's what you use, that's manageable. You're experiencing pain, but it's okay. It's being managed appropriately because it's at a level that you are okay with without needing to ask for more support, more intervention, more something like that. So it allowed us to individualize as much as possible what was an acceptable amount of pain for that youth in that moment, recognizing that if we ask them that tomorrow, if we ask them that a week from now, if we ask them that 2 years from now, that an acceptable amount of pain could change, right? That's actually a movable target, that what you might say is acceptable to you today is going to change based on any number of factors, past experiences, context, all sorts of things. So it's a complex answer to like a complex question, I think, right?
Oh, well, no, it was very well said. And Daniela has a question here as well, too.
Hi, everyone. That was a great presentation. Thank you. This is Vasilia. Vasilia, say hi. Oh, there you go.
Hi.
It is more like observation that this kind of about that acceptable or not acceptable and how they show the pain needs to be shared with all service providers, like doctors. I mean, they didn't believe me that Vasilia is in pain and he had a kidney stone stuck in his kidney. Okay. So imagine the amount of pain because he's not crying. Usually he's not crying.
Yeah.
Depends how he shows that, right? That is where you come to the point where you need to trust the parent.
Yeah. I couldn't agree more, Daniela. And I think for all sorts of people, that's the case. And there's actually a really interesting study that was done a few years ago showing that actually kids are very good at suppressing pain. They're not very good at faking pain. So actually you're more likely to see a youth who is hiding actually how much pain. I'm not saying that's the instance with the youth that you're with, but that I think is a really interesting notion because sometimes we hear like, a youth might be expressing pain to get out of something, right? Or to, and so actually kids are pretty good at suppressing it. The other component is when there's something else present and pain is present and we can't see the cause, we often dismiss it, right? So in that instance, you're describing, in the context of other disability or different abilities that people can say, well, it's part of that condition, right? Or we don't know, maybe that behavior is part of that condition. The other example of that is we see a lot of youth with chronic pain are 2 to 3 times more likely than their peers to also deal with mental health issues. And chronic pain is more common in teen girls than teen boys. So if you're an anxious teen girl and you have chronic pain, it's more likely to be dismissed as a mental health issue than it is as kind of a true primary pain disorder. So because we can't see pain sometimes, it gets dismissed a lot. And, that's one thing certainly with Skip that we're really working to do, is to increase that awareness that pain in children is real. It's something we need to get better at identifying. It's something we need to talk about more with everybody, right? The public, teachers, coaches, respite workers, parents, siblings, healthcare professionals, all of it, because the number of stories I've heard from families, and maybe Mylene, this has been your experience too, whose pain has been dismissed or ignored, that's probably the number one thing that I hear as like a commonality across lived experience.
Mm. And we brought up a few times just what the experience of disabled young folk and things like that. I never told you the story before, Katie, but one of the interesting things from the other side after Luke passed was I've kind of felt compelled to kind of write down some of my experiences in terms of what that loss meant. And I've been able to talk to a few families who have recently lost their own young folks as well too with their family. And one of the things that I didn't consider before was that interconnected feeling was raising someone who was nonverbal and what that meant to lose that. And to explain that to someone else, why they kept hearing sounds and being triggered by certain things, that played such a role in terms of how connected we are, and moving that forward is going to be a very important conversation to talk about in the future. But we have one last question here tonight, and that is with Justine, who's got a squirrely young man there who as well, and I miss him dearly.
Well, I did have something to say, but I feel like you and Danielle and Katie have basically touched on all of it. Was that like we said, for our nonverbal population, it's challenging or has extra challenges in terms of sometimes having that believable factor and being able to express and describe and, really focus in on pain and having it treated. But from my own experience, even as a young teenager with pain, I remember the most frustrating experience would be showing up to emerge, sometimes by myself because I had a car and I could do that. And having to actually present a letter from my physician that says, this is Justine, she is 16 and she won't be crying and she is in pain and you should take her seriously. Don't bother calling her parents. And that was really, I think, for me, for someone who is generally such a good self-advocate and verbal and relatively capable individual, to have all of those barriers to accessing care myself. All of that is tenfold when it comes to accessing care for my sister or for any of my clients in my professional life. And being able to be that voice and advocate is sometimes can be incredibly challenging, even with all those skills.
Yeah, I appreciate that, Justine, and it's nice to see you here. One of the things that, this is where I was talking about how I think the science and the conversation, I hope, along with organizations like Skip, but others as well, is changing it, is a lot of healthcare professionals for billing purposes and other things use what's called the International Classifications of Disease, which is is a diagnostic classification from the World Health Organization. And for the first time ever in 2019, pain is included as its own diagnosis. So there is a primary pain disorder and a secondary pain disorder. Primary pain is secondary pain is if you have pain associated with another diagnosed underlying health condition, such as arthritis or something like that. But primary pain is a pain condition. So it can be in the absence of another diagnosed health condition. And I think this is really, our health systems are not there yet, because it relies on, when you go in now, your visit is coded based on previous versions of the International Classification of Disease, like the 9 or 10 version. So the health system is not yet at the 11th version, but it will be at some point. But I brought that up with a lot of families and youth because we presented some of that to teachers a couple of years ago within the Calgary Board of Education. And they were teachers that support kids with individualized program plans and other special needs or different needs. And they were thrilled to hear about that because they said, oh, that kid that I've got that has chronic pain, I don't have to add a mental health code for this kid. They don't have another underlying condition. I can use primary pain. And we were like, yes, and you should. And I think hopefully add some more, this is not the word I want to use, but I will use it, legitimacy to pain being a condition in and of itself that can co-occur with other things, but doesn't have to.
Well, thank you so much for all that you've shared here today. I wanted to just give one last kind of takeaway message from what this conversation has been all about tonight. So I had the privilege of partnering with Katie on a paper recently about the change in definition of pain. And one of the experiences that came out of that in terms of partnership, and what I love about an environment upon which there's opportunity to really share your experiences, was Katie we sat down and with another stakeholder as well, and she just kind of said, so what are we talking about? And we just had a great conversation. And from that, what ended up happening was to say, well, yeah, they changed the definition of pain. The stakeholder experience was, well, so what? What's that all about? Like, why should we care? What are we wanting to see? And so when it comes to seeing environments upon which you can have the comfort to have those types of conversations and just be brutally honest, those are slowly emerging, and researchers are sharing those practices and finding opportunities to be more open. From our end as patients and parents and things like that, one really great bit of advice to share is to speak up. Sometimes the worst thing people can say is no, in terms of having connections, talking about research, things like that, creating suggestions and things like that. Sometimes it just takes a little bit of work to kind of nudge people into a movement, but it does happen. Within my own hospital experience, I was talking about connecting in research for many, many years. And then someone from our family engagement and research course did their final project there to talk about partnership, and everyone went, we are so far behind. And that was the catalyst to move things forward. But somebody spoke up, and then somebody else helped move the needle. And when we can all be brave and have those conversations and speak up together, then we can start really authentically collaborating. So thank you again, Katie and Mylene, for both coming here tonight. We do have an experience welcome to for, let's say, the next 10 minutes or so, if you want to kind of process what was talked about, things like that. It's informal. Come hang out with us here. It's on the same Zoom channel here, so you're welcome to stick around for a few more minutes just to chat.
Thanks for having us.
Yes, thank you for coming.